Welcome to this Mtech Access webinar. At Mtech Access, we provide health economics and outcomes research and market access services from strategy through to implementation. We work with over 80 NHS associates to bring our pharmaceutical and medtech clients authentic insights into the NHS. Our unique NHS relationships guide and validate everything we do in the UK. We can help you answer key questions related to the NHS, from how to communicate with integrated care systems, places and primary care networks, to how to capture pathways of care. Get in touch today to discuss your market access goals. First though, I hope you enjoy the webinar.
Today, I'm delighted to be joined by Ellen Rule, who's the Programme Director for the Gloucestershire Integrated Care System, author also of the recent NHS Clinical Commissioner's paper, Systemisation of Medicines Optimisation. That's not easy to say on a Friday afternoon. Ellen's worked for the NHS since 2003, holding a variety of senior positions in commissioning and provider organisations. She holds a Master's in Health Economics and Policy and currently sits on 2 national committees for NICE. Prior to that, Ellen worked as a civil servant in the Cabinet Office and in the private sector in financial services, so has a really good appreciation of all things healthcare and all things value, which we'll get stuck into now. Ellen, welcome. Thank you for joining me today. Hopefully that intro has done you justice.
Thank you.
Really looking forward to a chat today. So as a starting point today, could you just introduce yourself briefly? What does your role of Programme Director in ICS mean, and what does the system itself look like?
Thanks, Tom, and sorry about causing you that slight stress about the audio and myself. I'm glad it's worked. It's also with this webinar setup, I don't actually know how to blur my background, so apologies that you have to look at my storage behind.
We've had worse,
So yeah, thank you for that introduction. So my role at the moment is one that's actually in transition, because obviously we're responding at the moment to the upcoming legislation creating integrated care systems and integrated care boards. So I have a kind of double role at the moment, being a Director of Transformation in a clinical commissioning group. Obviously clinical commissioning groups will cease to be at the end of March, and we will become formally the integrated care system. And as you've said, I'm also a Programme Director for the integrated care system, so I hold a kind of strategic role in the system, but I'm also responsible for a lot of the work of setting up the new integrated care structures, the transition programme as we call it. Both sort of designing how the ICB will work and how we will relate to other parts of the system. Hence, I was able to apply that into the report that you've mentioned that I've recently written, which is in part seeking to capture the legacy of medicines optimisation work in clinical commissioning groups, but also then to start to think about some perspectives of how that might be taken forward into the new context of systems, using that lovely word, as you said, systematization. It was actually an NHS England's word, I must say. I didn't make that one up myself. But that's very much the business of what they're thinking about at the moment. How do we systematize into the new integrated care systems the way that we work around key issues, obviously in this case, medicines optimization?
Yeah, fantastic. Thank you. So I'm taking from that systematization then is going to be applied across the piece. It's not just the medicines, but then it's all elements of care. Is that right? Yeah.
I think yes. It's the way that we need to think about transformation in the future NHS, and I think although it might sound complex, all it's really saying is it's about all parts of the NHS working together. And probably people who don't work in the NHS would think, well, why don't you just do that anyway? But I think that over the history we've had since the kind of, it's been quite a long one really, around kind of payment by results and foundation trusts and setting up separate commissioning and provider entities, you had much more of a kind of quasi-market competitive environment within the NHS, where people weren't necessarily always completely aligned in the objectives that they were seeking to achieve at the organisational level. And of course, the NHS is really just a big collection of lots of different organisations with the NHS sort of brand over the top. And so this is really saying that in future we should all work together and aligning the incentives in a different way. And so yes, it does apply across all kind of areas of care. I would say that we don't always know what that will mean yet, so obviously the thinking's quite early. But what we were seeking to do here is to start to think about how that could work in practice. So what would the components of a systemized approach to medicines optimization look like? And I think some of those components are just generic ones that you could apply. You could change the title from medicines optimization to, you know, whatever you wanted really. And things like having one team that worked together in a collaborative way across the system would apply. You know, having joined up digital and data would apply. They're not unique to this area. Although I think there are aspects of our report which probably are more specific to medicines and some of the historical issues we've had around medicines optimization and how we might improve on that in the future.
Yeah, brilliant. Thank you. We'll come back to the systematization piece shortly, but you mentioned ICBs, which I'm sure is one of several acronyms that we'll wheel through this afternoon. Could you just give a bit of a window into how the systems develop and some of the sort of structural stuff and the decision-making processes that are going on?
Yeah, and it's happy to. I mean, it's really early days with some of that, but just so people are clear, because there is a huge amount of acronyms that we talk about in the NHS, and you must stop me if I use any others without explaining them. But we have, so an integrated care system will be obviously all the partners who work within a particular geography, and across the country, those geographies are not all the same. In fact, some are really quite different. So the system that I work in, Gloucestershire, is one of the smallest ICSs. It's less than 1 million population. The boundary is coterminous with the CCG boundary as was, and we have a one-to-one-to-one relationship. So we have one acute hospital, that Gloucestershire Hospitals Trust, that serves our county. We have one local authority, albeit it's a two-tier local authority. We have one health and care trust, which is an integrated mental health and community trust. And our boundaries are all the same. Now, you have other integrated care systems that will cover huge geographies of kind of 4 million people, where they may be incorporating 3 or 4 CCGs that used to exist, multiple local authorities, multiple trusts. So the size and scale of different ICSs is quite different across the systems in the country. And we then have, at the top of that integrated care system, we have what's called an integrated care board, so the ICB, and that will be a partnership board from those different memberships across the system. Now, it's not a representative board, so what I mean is you don't have to have every single member organisation sitting around the table. So in Gloucestershire, we probably will have every single organisation sitting around the table, but that's a lot easier to achieve because there's 4 of them. If you are one of those really huge areas that I talked about and there's maybe 20 organisations, you obviously would struggle, not least to sort of manage and have a sensible conversation at that board. So there will be that partnership board at the top, and it isn't necessarily a representative model, but it will have a flavour of the different parts of the NHS. And you will have levels of delegation. So people will then have place, which is the name for it we're using in the NHS, which in some of those really big ICSs is going to be a similar footprint to the original CCGs. And they will then be kind of localities within the ICS. Now, in a really small one like Gloucestershire, I realize this might sound a bit confusing, but probably how place is defined in the national architecture is coterminous with our ICS. So Gloucestershire is probably a place and an ICS, whereas in, say, West Yorkshire and Harrogate, you've probably got 4 or 5 of them. And depending on the size, the resources may or may not be then delegated down to place. So you end up with ICSs being reasonably, again, different at that top level. The way I would describe it in a kind of simplistic way is that you could think of it as like a thin ICS, where what you're taking up to that ICS level is relatively minimal and you're delegating a lot down, or a thick one, where actually most of the kind of business is being done at that ICS level and very relatively little is delegated to place. And then we also have an integrated care partnership that will sit alongside the integrated care board. And that will be another board which includes then wider partners like local authorities and so on. And that, I think, candidly, is a bit of a fudge, whereby the NHS wants a point at which it can hold itself accountable for the money. So effectively resources are delegated to the ICB. But it wants a board where it also has local authorities and others who are maybe not directly accountable. So that's why I think we've ended up with two bodies at the top of ICSs. And our job at the moment is just defining how we will incorporate all of the CCG statutory functions into that ICB with that new partner membership model. For people who like to talk about governance, there's a lot to think about there. And structure all of that and manage that relationship with an ICP, which then also has a relationship with the Health and Wellbeing Board. So quite a bit of complexity in the structure that we're designing and setting up at the moment. But the view is that at least all those NHS partners for a geography will be together with a shared set of objectives around managing resources in the best interest of their population.
Yeah, and it's interesting you talk about the complexity for you, whereas actually yours is quite straightforward. And I guess you go to other parts of the country, it'll be very different. And one thing I think that our audience sometimes, or all of us, I think, struggle with is how much is this a nominated or a template architecture, you slot your own bits. And I think what we're taking from what you're saying is that actually a lot of this is kind of bottom up, and you've got almost the acronyms that you need to conform to, but actually you've got to think locally about how does this work for us and one place or three places or what have you. And then the thick or the thin, there's going to be a huge amount of variation, I guess, between the 42, isn't there?
Yeah, there absolutely is. And I think there is that ambition around kind of local determination in the way we set it up. I mean, there are some standard roles that we are required to have, but they are a very small number. So some members of the Integrated Care Board will be set nationally. So obviously every ICB will have a chair and a CEO. And then there are just a very small number of standardised roles. So each ICB will have a Chief Medical Officer, a CMO, and a Chief Nursing Officer, a CNO, and a Chief Financial Officer, so a CFO. And then there are a couple of kind of recommended but not specified jobs around Chief Digital Officers and Chief People Officers. But beyond that, there's very little in the way of direction about what those boards might look like, what the key roles might look like. Different systems have very different views about that, I think, based on their legacy. So in Gloucestershire, as I say, being a relatively small system, and I would say having been working at it for a while, we have a reasonably mature partnership. And so we have got, for example, elected members and people from our local authority on our board now. We wouldn't really have needed an integrated care partnership. And at one time we were trying to test if we could just run it as one thing or merge it with our Health and Wellbeing Board to kind of cut down on the number of committees. Now we can't do that because they've been given distinct statutory duties in the legislation, but we are going to try and do things that give us economy of scale, like in fact, I think the Health and Wellbeing Board is most like the ICP, so we might try and sort of run them in the same session. You could open one, you start it, you finish it, you say, and now we're going to be the ICP, and you carry on. And we've been taking legal advice on the opportunity to do that. But I think for some of those other systems, like some of the ones where the Secretary of State only determined some geography, so there were some boundary changes. They were only determined relatively recently. You've got areas starting from complete scratch in terms of there's a new geography they're incorporating into their ICS. So you can see how that would be a much more complicated journey to go on than one where you kind of already know what your membership would be and how it would work.
Yeah, fantastic. Thank you. Yeah, it's going to be a long journey for a lot of places, isn't it? So thinking specifically about your role within the ICS, it's heavily linked with delivering value across the system in a whole host of different ways. Can you help us to understand a bit more about perspectives around value and how that's evolving?
Yes. So again, I mean, it's interesting because in terms of sort of sharing learning, then I think some of the terminology that we use in our system may not be the same as other systems, but I imagine quite a bit of the philosophy would be very similar. So in Gloucestershire, we work in a way called largely around value, around something called the clinical programmes approach. So we have pathway networks that go across our system. So we encourage, so this is where I'm saying we were reasonably systematized, to use that word already, in Gloucestershire. So those are kind of network groups, if you like, where we put together clinicians working in all different sectors. So people from primary care, GPs, community, mental health, depending on the relevance, acute care consultants. We also have around that table patient and public representatives and kind of users by experience, and we support them with experienced kind of program managers and people who are good at informatics or finance and that kind of thing. And then what we ask them to look at the disease area, and so usually obviously those people are there because they have a specific interest in that. So we have clinical program groups, as we call those networks, for a whole range of clinical areas. So we have a diabetic one, we have a circulatory one, we have a respiratory one, we have one for ophthalmology or eye health as we call it, MSK, pain as a subset of MSK, and so on and so forth. And because that's a very distributed leadership model, you're not really restricted in almost how many times you can replicate that model because you're drawing on different groups of people each time. Although obviously the thing that I quite often do get stretched in is having enough program and expertise in the kind of informatics and finance to support all the things that they want to know. And so we then have a kind of theory of change model that says you pull in a number of different facts and figures and information and knowledge about your program area. So that will include the use of resources, adherence to best practice, current performance. So we do link, not everybody does link transformation and performance, but we do. So is your service delivering a good waiting time standard? Is it meeting patient experience objectives, that kind of thing? The perspectives from the kind of, we do sort of benchmarking. So we'll look at, we get things like the Right Care Where to Look packs and national benchmarking data, although sometimes there's an issue with kind of data cleanliness. And obviously the clinical voice. So you put all of that together and we say, like, where are the opportunities to deliver increased value in that programme? And that, by that I mean better health outcomes for the pounds we spend. So that's an incremental improvement journey. You're spending X, this is the outcome you're getting. Can you increase that value within the programme? So you're looking for, you're interested in the outcomes that you can measure for that population. How do we do against kind of things like national audits? So for some clinical areas, that's really easy to find. For example, if you are looking at the diabetes clinical programme, you've got the 3 care outcomes and the 8 care processes that we get measured on for diabetic care. That's a kind of national standard. And for stroke, for example, we have something called the SNAP audit, which is a national audit of stroke performance across the pathway. Whereas for other things, you might be using more locally derived data. And then you think in the group, they decide what they're looking to target. So where do we feel that outcomes are poorer for our population, or there's an opportunity to save resources to spend them on something else? So we're not talking about, I think it's always worth saying that when the NHS talks about savings, it's never talking about money to put in the back pocket. It's always about, there's always a million things we could fund that we don't have the resources for. So we're thinking all the time, is there any waste or inefficiency or, you know, less good use of resources that we could redeploy on something better? So it isn't necessarily something that's not valuable, but there might be something else you could do which would be even better.
Is there any ring fencing, Ellen? So you're looking at a diabetes program or a circulatory program. How does that work? Do you have £1 million for that, and then you keep that money within there and shift it around? Or is it, okay, well, if we can save £50,000, maybe we'll put that towards stroke or something like that?
Mm. Yeah, it's a really good question, because one of the things that's really, really difficult in the NHS is sort of dropping the hat over the resources that belongs to any particular area. So I think, as you said in my introduction, I'm a health economist by training. So this is sort of based on a theoretical model called program budgeting and marginal analysis. And in the theoretical model, program budgeting would say you get the budget for your program, and marginal analysis would say, in the simplest form, you move money around at the margins to increase that value per pound. Now, in reality, identifying the program budget is really difficult, and you could sort of disappear down a data black hole probably for years trying to absolutely define the program budget for any of those given areas. But what you can usually do is identify areas which you think are amenable to change. So there are some things, it's not exactly what you asked, but they're not exactly ring fence, but there are things where it will be harder to extract cost, and then areas where you know that there is a greater degree of need, and also areas where you think there might be lower hanging fruit. So what we tend to do is to encourage people to look for the things that they identify that they think they can change, and then to work at the margins, if you like, to focus on the marginal analysis and think about how they could change from one thing to another. So, of course, if you think about the three main things that the NHS spends money on, which I've had summarised to me before as beds, meds and heads, it's quite hard to get your money out of beds and physical buildings. It's reasonably hard to get your money out of heads, and it's slightly easier to get, but not easy by any means, to get your money out of meds, or certainly to analyse it and think about how you might use it more effectively. And even with sometimes with the sort of heads bit, it might be about using the staff you've got more efficiently, or by freeing up their time, you can deploy them to do something else which would be more valuable. So it's not necessarily, again, it's not about taking it away, it's about recycling all the time that resource into something else that you could do, maybe through a cheaper version of the thing that you're doing. So to give you an example, in our eye health clinical programme, part of our sort of status assessment was a range of things, but really severe waiting times around some of our lists for things like glaucoma follow-up care, and patients who are on roll forward follow-up of kind of year plus. So they were meant to be seen at 3 monthly intervals, and that had been rolled forward, and they were sort of 15, 18 months, possibly with a really significant detriment to their care. And to cut a long story short, we effectively were able, we set up a contract with our community optometrists, which was a much cheaper model of follow-up care rather than hospital-based consultants, stratified the patients, and for a big cohort of the lower risk people, they were then able to get the follow-up in the community at much cheaper cost per attendance. We didn't cut the consultants, but we were able to achieve a significant performance and health outcome improvement by then redeploying that consultant time onto seeing patients more readily and starting to move down that waiting list. So sometimes your marginal analysis isn't about taking resources out. In fact, in that case, resources were slightly increased, but the performance was significantly increased and improved in terms of the outcome for the patients.
Yeah, okay, thank you. So, I mean, I think that the areas that you've talked about there, a lot of them are areas that probably there's a lot of expertise within the system. Specialised commissioning is something that's coming down to ICS level. So is that going to be managed in a similar way, or is that going to be kind of a bucket on its own because of the nature of what's in there?
Yeah, and I would say that we don't have a huge amount of information about that at the moment. We know that it will be delegated, but the last information that I heard was that there was a view that it would be delegated, but with national specifications and effectively service level agreements, in which case my observation would be it's not delegated. We're just administering it. Because if you can't set the specification for the service or the local agreement, then you are just a kind of postbox for that. And I'm not necessarily saying that that's a bad or a good thing. It's just, I would say it's just not delegated. So I think at the moment we don't know what that will look like and whether it will be delegated or whether local systems will still have quite a minimal role. I would say that so there are some things, when you look at the specialised collection of services, they can be kind of divided into about sort of 3 tiers, I would say. And some are very much highly specialised orphan treatments, things that really should stay at a national level. And I can't think of a single ICS, or if they were interested in it, I don't know why they would be, because there would be very little benefit in taking that into local commissioning. I think there's a sort of middle, much more regional tier where you could see some benefit in ICSs having more involvement, but in a networked model. And I don't think that would be something that would happen soon. But there is a cohort of services that went into specialised on the last transfer and came out of local services that would probably be better if they were more integrated, particularly, for example, around cardiac care and cancer care. So they're so most hospitals deliver them. They're not really highly specialised, and there would be benefits from integrating that more closely into local commissioning. So I think we can list a set of things that we think were the opportunity there, we'd have a lot more appetite to take delegated for than some of the other things on the list, if you see what I mean.
Yeah, absolutely. Yeah, that makes perfect sense. Thank you. So we're going to stay on the subject of medicines and move on to your paper, which I know everyone's keen to hear a bit of commentary around. Just as a bit of a headline, I suppose, obviously medicines optimization is something that most people will be familiar with in the audience, and it's been characterized in certain ways. So could you just kind of give us an outline of the brief and the objectives of the task you were setting and pulling that together?
So it was something that so I guess just thinking back to when we decided to write it, it was not necessarily, we won't set it as a brief by anybody. It was our thought. I'm not sure if people are aware of the kind of the NHS Confederation and NHS Clinical Commissioners and the position it has. So NHS Clinical Commissioners is a membership organisation for all clinical commissioning groups, in the country. So it's a kind of, it's a membership body is the best way of describing it. I suppose it would be like the ABPI for some people who would be listening on that call is NHSCC, and it's part of the NHS Confederation. It's independent and all CCGs are members of it. I've been involved for quite a long time with NHSCC in a variety of ways with my interest in medicines. And I represent them on a number of key national forums, including things like the Medicines Value Programme Board and so on. So we were aware of work that was going on at the national level around starting to think about the future of medicines optimisation in integrated care systems, particularly using this terminology, systematization. And so we wanted to put, I suppose, sort of put our oar in, really, if you like, in terms of both having an opportunity to capture the legacy of CCGs, which we thought was really important, given we think CCGs have done a lot of good work, and then to put forward a perspective to inform ICSs of what we thought the lessons learnt were from the experience of CCGs to date and people starting to work in an integrated way. So we came up with that idea ourselves and kind of designed the approach. So myself and working with some of the people from NHS-CC. So obviously I co-authored it with Ed, who's one of their policy leads. But it was something we really generated ourselves in terms of thinking it would be good to capture that learning and to be able to inform the debate in the future, rather than CCGs kind of just sort of fade away and no one really record a lot of the great work that's going on out there. So we did a number of things to pull that together, including sort of desk research, looking at some of the literature, but then pulling together, the most important part was pulling together focus groups of people from across the country who are leading medicines optimisation in their systems and in their CCGs. And I chaired that series of focus groups, and we pulled out those themes, which is what forms the recommendations, highlighted with some case studies from people who came and spoke at those focus groups. And we tested it with various people before publishing that, and we intend as well then for the Confederation to host a learning event probably in the new year, to again sort of go over some of the learning and to try and launch that into the integrated care systems. And one of the things that the Confederation do, as I think a lot of membership bodies do, is they're interested in the kind of reach and interest that different pieces of work they've decided to do have got. And the feedback we've had is that this has generated a huge amount of interest, actually, and has been really accessed a lot of times by people in senior decision-making positions in NHS England and so on, which I think is hugely positive, and it shows that people were interested in the kind of thoughts of systems and people working across the country to deliver medicines optimisation and the sort of lessons learned and how those can be applied to ICSs. But there wasn't a mandate to do it, we just decided to do it ourselves.
Yeah, fantastic. Yeah, and I think something that our audience may or may not be aware of is exactly what you've illustrated there, that the clinical commissioners is effectively the people that are doing the doing. So it's not kind of a think tank or a policy group or something that's commenting from the outside. It's actually that lived experience of this is what's good and this is what's worked and this was what we should keep as well, isn't it? So in terms of the recommendations that you've come up with within the paper, which do you think are most important within there?
Well, I've just realised I've actually left it upstairs. So as I came downstairs to get nearer the thing. So this would be a good test for me from my memory of writing it. I mean, I think, gosh, what's the most important? I think probably integrating medicines optimisation into the wider pathway work and the clinical agenda. So not seeing it as just the business of pharmacists or something that sits out to the side, but that if you really want to think differently about medicines, it needs to be fully integrated into clinical pathway redesign. Medicines are not a standalone issue. I mean, there's a slight irony, isn't there, to ask pharmacists to be in charge of improving the use of medicines when the vast majority of prescriptions are written by doctors. So if you don't involve them in the thinking, then you're unlikely to change the behaviour and to change the practice in the ways that you might want to do so. So I think probably that is the most important thing that I would pick out of the report. it was something that I felt myself, but that came through really strongly as well. I think also, and sort of fitting in with that, is the concept of the one team. So people working together across community hospital, obviously that's in line with ICS thinking, but people talked a lot about that and about how they had invested in developing the team, particularly working across, now we've got all these different roles like the PCN pharmacists, so primary care network pharmacists, and you've got community pharmacy, obviously starting to think about things like rotational roles and how you really bring those together, so that you get that sense of that one team, even though people might have different bases for their work. I think that came across as really important. And then I think the thing that we really wanted to play back strongly to the sort of national level as well is that sort of, I think I described it as a sort of virtuous cycle. I think there's a diagram towards the end about what regions can do, what national can do, what local can do, and that us also getting a clear idea of our different roles, because I think at the moment that's sometimes quite confused, and that you get sometimes, you know, bilateral sort of price negotiations, what I would call quite transactional things happening at really local levels, which might be good because you get a good price deal for a short period of time, but actually, is it a great use of time? And if you had the purchasing power of the whole NHS, I know this is reasonably controversial, but I think those kind of transactional conversations could happen better at a national level, whereas things that are really about how you embed good practice and work with the local clinical teams work much better at a local level, where you've got actual identified leadership and a clinician who's going to take local clinicians with them, rather than, you know, sort of delegating something from on high that then people may or may not sort of pay attention to. So I think it's about also identifying the right level of different actions and where they can be most effective for the future as well.
Yeah, thank you. And yeah, I mean, what you're talking about there really is making things work as a system. So really that word of systematization, it is all about that, isn't it? One thing that, one of the recommendations that you've put in there that certainly has generated a lot of interesting conversations we've had is around single national formulary. And I know that, you know, there's lots of different perspectives on that. Could you just expand a bit on the thinking around that as a recommendation?
Well, and I think, just to be clear, we didn't recommend that there should be one. We said it would be worth exploring if it would add any value. And I must admit, we deliberated long and hard about whether to even include it, because it came out of one focus group. It wasn't necessarily a theme in all four. And it should be recognised that we wanted to be true to what people said. So, and it was interesting that came more. We had representative people from across actually all aspects of the NHS, so not just CCGs, although we were really interested in the kind of CCG legacy. So that came actually more strongly on the group. We had more members from acute hospitals, so head pharmacists from the hospital sector. So I think in a way we almost put it in there as a bit of a provocation, of a question: would that be useful or would it not? And also I think you can see there may be more cases for it with certain things than there are across the whole. I mean, the other issue is that if you did that, you could potentially create a bottleneck. But then equally, the flip side is that we get lots of things produced lots of times over with lots of management effort and lots of local discussions, whereas sometimes the sort of do, wants and share would be better. So yeah. I think just we did not recommend it. We said, should there be a conversation about what it would mean if you did it, and then could some of the benefits of that be applied in some way, rather than thinking that it would be actually practical to try to do that. Plus, politically, I don't think the appetite would be there anyway, because no government wants to say they have made a menu of what is and is not available on the NHS at a national level.
Yeah, absolutely. Yeah, so what I'm taking from that is that there'll still be these levels of decision making, and a lot of it is just kind of jiggling that around, I suppose. Well, another thing that our audience is always interested in is kind of implementation of guidelines. So in terms of this piece around systematization and getting everyone working more cohesively, do you see that having an impact in how guidelines are implemented?
Yes, and I think that's my point about embedding it in clinical pathways, because guidelines is a really interesting one, because obviously not nice TA, that's compulsory, but nice guidance is discretionary effectively to the NHS, and it does depend on local resources to what extent some of that is implemented or not. And our experience is that you do need to think about the local conditions and the resources you have and to shape local guidance. So you might start with national guidance, but you apply your own specific conditions to that. So certainly, like for example, in the work I described around clinical programme groups, we do define our own pathways and our guidelines around use of certain things, but within reason. So obviously not core. We might start with the NICE guideline and then we're maybe tweaking around the edges. So I realise that is complex when you're sort of looking from the outside in and thinking there's all these different areas and sort of how do we engage, but I think it will always be like that, because the point of it is to be responsive to local needs and local conditions, and that's why we need that flexibility, really.
Yeah, okay. So the idea of a decision being made at an ICS level that this is the guideline we're going to implement, and then suddenly it's cascaded and everything is done uniformly across the whole system is probably not quite how it's going to play out. It'll be, you know, maybe 60% will be there, and then there'll be a bit around the margins of deviation.
Well, I think,
need.
Yeah, I mean, I think, and your audience, people listening to this will understand this as well, is that prescribers are individuals who work individualistically, don't they? So there is a degree to which they follow guidelines, and there's a degree to which they have the freedom to practice their independent clinical discretion. And so it's a really interesting challenge when you're looking to get more conformity, if you like, or consistency in the way that you influence prescribing behaviour. This is one of the things I spent quite a bit of time studying, and there is research out there that says that it is quite difficult to change prescribing behaviour, and different studies have shown it can be quite impervious to change. And if you think about a GP, and they are maybe the vast range of different clinical areas they're dealing with, they're not going to read every bit of guidance that's out there and follow a guideline. I think that's not really realistic. So that's my point about, you might get something designed at the ICS level or at place, but the implementation and the leadership, and why I think you need to be talking to the whole team and not just the pharmacists, is going to be through that clinical leadership model. And that's the thing, when you said, you know, what's the most important thing in the report, I think that I come back to that, because if you don't have that local leadership from the medical leadership, you're not going to get the changes that you want to see. So you need people driving that and sort of educating at scale, and often we don't have huge amounts of resources to do that ourselves in the NHS, but I think we do need to do that. You know, the work I was doing around pain, and that was in part a prescribing programme. We didn't call it one, interestingly, but we have delivered probably over 1,000 contacts of training around that across GPs, across pharmacists, across community staff, and more than once. And we've incentivised people to take part in reviewing their patients. And you have to keep doing it. it's sort of like, you know, to change a habit is really hard, isn't it? You have to keep chasing that behavior change, monitoring the data, providing the feedback. So it's not terribly easy to achieve that that systemized response. So I think that's why you might, even if you design your guideline at a higher level, you need the leadership at the local level to drive adoption and actually and spread of the change that you want to see.
Yeah, fantastic. I'm learning so much from you today, and it's fantastic. Just to, I suppose, play devil's advocate for a minute. Think about that independence of behaviour and kind of the acceptance of that. What happens if there's not a more systematic approach to medicines in the future?
So I think the risk is that we don't give the best to our patients. So because not each, if you leave it down to each individual to make their own independent decisions about everything, and that individual can't assimilate the best practice or doesn't know the sort of wider context, and why would they, then you're not going to get the best outcome for the patient. Because if we come back to sort of full circle to what I was talking about earlier on about the kind of the theory behind the clinical program approach about best value, which is outcomes per pound spent. If our program group have looked at that pathway and said, if we use more of X and less of Y, there's more value and better outcomes for our patients. And we don't implement that, and actually people just carry on using Y because they always did and they don't really know about X, then we don't maximize value. So I think we have a responsibility to do it, because the things that we're asking people to do when we're trying to chase down is to improve outcomes for our patients. So for example, around that opioids work that I was saying, we were taking people who were we could identify as being on actively harmful combinations of prescription medicines, and they've ended up there because of, you could say, is that just poor care? But often they've ended up there through a quite a complicated and convoluted journey, and maybe the GP who's ended up holding that particular sort of basket of problems doesn't necessarily have the solutions to get out of it. And actually things being used against the recommended way of using them, you know, doses too high, combinations that we know to be unsafe, and those guidelines are out there. So you could say, well, why have people not just changed that? Well, they haven't changed it because it's really difficult to change, or maybe they don't have the time, or maybe they didn't know quite what the evidence said about how bad it was for some of those people. You know, there's a whole host of reasons you could look at. But the group sitting in the centre, that clinical programme, they can look at it and say, we can see that is not a good outcome for the patient, and then drive that across, you know, our system. And we also, and when we were doing that work, we engaged the clinicians across the county more broadly when we had the training, and we brought them in around, when we do free up some of this resource, how would you see us spending it to a better effect for the patient? So I think engaging them in the way it could be deployed more positively, again, helps to cement this is why I'm making the change, if you see what I mean. So getting them involved in the whole circle. And a lot of people then, you know, they said, you know, these people are the ones that I absolutely dread seeing on my list. I know this is not a good situation for them. I feel really exposed on, you know, I write this prescription, but I feel like, again, without sounding over dramatic, someone said, you know, I write this prescription, but I feel like I'm going to end up in the coroner's court having to account for why I kept writing this prescription. I didn't really know what else to do. So they were, you know, hugely relieved to be supported, and actually us to say, no, it is right, you should be changing this. And then we can help you, and then we've given you backup, and there's someone else who can help if you have a real problem here. So I think that it's a bit of a long-winded response to your answer, but I guess if you leave it all down to individual action, you never get that collective wisdom and then support to get the very best value for each of our patients, which is what we are at the end of the day trying to do.
Yeah, that's a really great answer. We've just got a couple of minutes left. So how best do you think pharmaceutical companies and those in our audience might be able to support the NHS with the medicines optimization? in the future?
I think that, and I think I do see more of this actually, because I sit at the, as I said, the Medicines Value Programme Board. So some of the work that's been going on on partnership is happened through there. I think Inclisiran is public now, isn't it? So I can mention that. It's been in the news. So I think what I've seen is engagement and partnership working in trying to think about a kind of whole pathway. So that fits with what I've been saying about, I think the value proposition needs, and not always possible, I know, but where possible, it needs to be grounded in thinking about that kind of the context of the patient. So I think where products are sort of amenable to that, if that can be expressed, then I think that helps with the sort of work that we're trying to do, to think about, you know, sort of the holy grail with some of these things is I want to improve care and spend less. You know, those are the opportunities we're always looking for, aren't we? So, you know, that was the perfect thing for some of my living well with pain patients. Like, we were spending a lot and they were not feeling good. So we've managed to spend less and improve their quality of life with some of the things that we've done. Now, there are other ways we can do that if we can optimize care, because we know there's quite a lot of waste. There's still, I think, can't remember, it's on the top of my report. If I had it, I could tell you, but I think it's 6% of all hospital admissions are known to be from, you know, poorly either interacting drugs or non-compliance or whatever. So ways we can be thinking about, you know, whether it's tools that help with compliance, ways of thinking about how we can deliver greater stability in the patient's medical condition. I know I'm sort of thinking off the top of my head about sort of generalizable things from different products I've thought about, or some of the preventative things. I think that's where there is going to be interest, and also coming to the table to have an honest conversation about sort of price negotiations and things like that, which I know, again, some are more up for doing than others, and I understand why that would be. But I think that they want, you know, people want to have a conversation now. More, this would probably be more at the national level, where I think some of that transactional conversation is actually better placed. But can we link pricing to outcomes, and, you know, actually see the value come through and align in that way? Again, it's sort of easier to say that we want that. It has to be realistic about what you can measure, because linking pricing to outcomes is quite difficult. I sometimes think that our models in things like our NICE TAs and so on are reasonably optimistic. So again, I think we just need to be realistic about that. We can't expect people to price something in that they can't necessarily expect to be able to evidence. It has to be fair both ways, I think.
Yeah, absolutely. Yeah, thank you, Ellen, so much. We're going to have to call it a day there, I'm afraid. But yeah, certainly I could go on all afternoon. So thank you very much.
Sorry about the tech issue.
That's all right, no problem at all. It's the perils of this job is that we have that sometimes. But thank you again so much for joining me this afternoon. For everyone else at home, thank you for tuning in. I hope you've enjoyed that. If you want to hear more of the NHS insight that we bring, please get in touch. We, as an agency, cover everything from global strategy and to customer communication, and all of our work includes the insight that we get from our NHS colleagues. So please get in touch, info@mtechaccess.co.uk. If you want any more insight from us. I'm going to be back on November the 19th, where we'll be having another look at the mechanics of how the NHS is changing and what's really going on at a place level in how systems are evolving. So look forward to seeing you then. Thanks again to you, Ellen, and have a good weekend, everybody.
Thank you for watching. If you'd like to find out more about our work with the NHS or how we could support your market access goals, please email info@mtechaccess.co.uk or visit our website at mtechaccess.co.uk.